We have Ed Prideaux visiting us here today. So Ed is also a journalist, has been writing about HPPD for a while now, raising awareness, has been working with the Perception Restoration Foundation. And yeah, I mean, I will leave it to Ed to introduce himself more properly, but welcome.
Hello, thank you for coming to my talk. So I'm Ed. This is my talk on HPPD, and I'll go into what HPPD is and all about it shortly. So what will we cover today? There you go, I had to use this mouse. So it'll be an introduction to HPPD, why it matters, what helps HPPD, and I'll outline a possible CBT concept of the condition based on my master's research. So my story. So here is a picture of me on 200 micrograms of 1p LSD on that fateful day in 2016 when I decided it'd be a good idea to trip with two friends from school. And unfortunately, the trip took a bit of a downward turn in the following few days when I noticed that I was experiencing certain unusual visual, perceptual experiences several days later. And these visual experiences didn't quite go away. And then dissociative effects began coming on. And although I'm broadly recovered now, if not fully recovered, but it took basically a good 7 years with this HPPD. And I'm a journalist and forthcoming graduate from the University of East London in psychology. And I was doing my master's in order to do research on HPPD, funded by the Perception Restoration Foundation, which until recently was my employer. It's a charity launched by two people with HPPD to try and raise awareness and organize funds and motivate studies into HPPD. Yes, I became motivated to become more active on HPPD and sort of come out myself as having had the condition because of the psychedelic renaissance. In September 2021, I believe, it was a time of, I think, probably approaching the peak of the hype cycle at that point. And noticed that no one was really talking about HPPD. So I decided to sort of take a leap and go for it. So what is HPPD? This initialism I keep using. It stands for Hallucinogen Persisting Perception Disorder. And it's a DSM-5 term that at its simplest means that when you take psychedelics, although we'll learn that it's associated with non-psychedelic drug as well, but it's stereotypically associated with psychedelics, and your visual perception is changed long after the drugs have worn off and in ways that cause you distress and impairment. And that criterion of distress and impairment is really, I think, central. And it was what motivated my master's research, which was aiming to understand what actually are the correlates and what could be the causal drivers for people to become distressed and impaired, which is not a guarantee when you start exhibiting these symptoms. And so HPPD is not a never-ending trip, as some people might fear. In fact, it's something far more complex. So HPPD is associated with a cluster of visual effects, visual snow, or essentially an overlay of static or graininess in the field of vision. And this is something that some of you here might experience as well, whilst not having HPPD, especially if you turn the lights off, or if you're lying in your bed at night, you might notice graininess. But with HPPD, it seems that this ordinary perceptual tendency is ramped up and amplified. And after images, when you look at an object and look away, and there'll be a faint sort of bluish, in my experience it was blue or green, almost silhouetted form of the object after you look away. Halos around objects, so a sort of shimmering ring around an object, which can be of a variety of colors, geometric patterns, illusions of movement. And this can be sort of completely persistent, so that just constantly you're experiencing these kind of visuals, or it can be more episodic. And these correspond in the literature to sort of two types of HPPD. Type 1 is this episodic phenomenon, when it's just these episodes that can come on fairly unpredictably, or associated with things like fatigue, stress, and exhaustion, or if you've taken an intoxicant of some description, like caffeine or cannabis. And yeah, type 1 and type 2 HPPD. So even people that have persistent HPPD, where it just seems that their entire visual experience has been altered, that doesn't mean that it's constantly at the same intensity. You know, it varies as I said, with stress and tiredness and fatigue. And it is triggerable through single experiences at low doses. We don't know much about HPPD and its relationship with the frequency and intensity with which people use psychedelics, although it does seem that, if you use psychedelics heavily and frequently at high doses, one would expect that you're more likely to develop the condition. But I triggered HPPD after my 4th trip. I know of people who have triggered HPPD through microdosing. It's more likely with bad trips and the abuse of drugs and use at young ages, it seems, which is something I found in my research. And HPPD, whilst it's centrally characterized by these visual effects, it also is associated with certain non-visual effects. Just a sort of distributed, free-floating anxiety and panic, depersonalization, derealization, which I'm sure some of you are familiar with, this feeling of detachment from your own body, or the world around you ceases to feel real in any way. You can feel dreamlike. Tinnitus, somatic effects. I was telling Celia earlier about this phenomenon of head pressure, which people experience quite a lot of HPPD, where for some reason it feels like your head is a sort of inflating, pressurized balloon. It can be quite painful. Cognitive changes, confusion, difficulty processing information, almost like the sort of cognitive symptoms associated with ADHD. And I was telling really on the way here today that I experience a lot of lapses of memory and absent-mindedness and forgetfulness I never experienced before I took psychedelics, although it was a long time ago, so we can never predict. But I would not be surprised if, with more research, we find that as well as the perceptual processing centers being affected by psychedelics, this can be associated with certain cognitive changes as well. I mean, we see people reporting even sort of dyslexic type symptoms with HPPD, or even a friend of mine experiences stammering that they never experienced before. So it's under-researched, these non-visual effects, and their relationship to the visual core is unknown. It's interesting that Dr. Henry Abraham, who was a psychiatrist in Boston in the early 1970s, and the guy that sort of codified the HPPD diagnosis. So he did it based on streams of burnt out hippies, essentially, coming into the Boston General Psychiatric Facility. And they were reporting a wide variety of symptoms, not just HPPD perceptual style symptoms, which they probably would have called flashbacks back then, but also the confusion, the disruption to the sense of self, difficulties with emotional regulation. And Abraham took the discretionary decision to focus on the perceptual features because it was easier to measure and it seemed more stereotypically sort of unique. So HPPD and its sort of central characterization as perceptual disorder, it was based on, as I said, a discretionary decision by a psychiatrist 50 years ago, and it seems to be a far broader condition. But at the same time, something I'm going to emphasize throughout the talk is that it's hard to separate HPPD from stress and anxiety. I mean, stress and anxiety are associated with all sorts of psychosomatic symptoms, for example, and that's not to mean it's all in your head, but mind and body are obviously extremely interconnected, and not least because HPPD, as I said in the previous slide, is sort of centrally defined by distress and impairment to a certain extent. So if you're stressed and anxious, it's kind of tautological. You're going to be stressed and anxious if you actually have HPPD. So the theories about HPPD, despite the fact that it is also a psychological disorder that defined about a certain psychological relationship with visuals, the theories around HPPD have been overwhelmingly neurobiological in the 50 years since we've been studying it, really. And it's the main theory as to how HPPD works is this theory that Abraham, the guy I mentioned earlier, came up with, known as the disinhibition hypothesis, which suggests that a drug like LSD, which was his main focus at the time, causes essentially a decoupling of the brain's visual filters, both during the experience and, he supposed, once the drug's acute effects have worn off. The visual filters are sort of, as I said, decoupled, and they remain decoupled. And HPPD overlaps significantly with other perceptual and sensory conditions. So whilst in the DSM, you'll find HPPD defined as a re-experiencing of the symptoms you saw tripping. So the DSM encourages this idea that it's a never-ending trip. But things like visual static and afterimages, which I mentioned in the previous slide, they can occur in a wide variety of other conditions. such as visual snow syndrome, which has been defined to exclude drugs. So it's possible that this HPPD diagnosis is really quite tentative, and it's deeply interconnected with other disorders. And the sort of central focus on drugs as the precipitant might only have a sort of limited utility. So we don't know the prevalence of HPPD, but I would say speculatively that it's not that rare. I mean, we've seen researchers in the last 10 years suggest that HPPD is exceptionally uncommon, extremely rare. I've seen estimates of 1 in 50,000. But the last study done in 2011 by Matthew Baggett, based on a sample of 2,500 people from Erowid, found it was around 1 in 25 of the sample noticed persistent visual effects that caused them some degree of distress. That meant that they were considering seeing a doctor. And then 3 in 5 of this sample had noticed some kind of persistent visual effect from psychedelics, whether transient or persistent. And this is not certainly non-trivial.
Can I just ask, is that, that's per dose or per person who's had
This is
experience?
Per person, yes. And it's worth mentioning, I think I might mention this in another slide, that this study is certainly, you've got to give it some caution in interpreting these results, because it's based on Erowid. And I think it was 61% of the sample, off the top of my head, had tried salvia, and I think it was 5% had tried all sorts of extremely exotic chemicals I'd never even heard of. So it's possible that this is not going to be representative of the broad psychedelic drug-using population. These are probably going to be heavier users, but at the same time, 1 in 25, it's certainly a cause for pause. So HPPD is fairly little known among the general public, as you can expect, and the current treatments on offer are fairly limited. I tried to inquire about treatments a few months ago, and I was told that they couldn't give me anything because there have been no controlled trials. So there's nothing they can prescribe anything for me. But usually you'll get given lamotrigine, which is an anticonvulsant, or they might prescribe an SSRI or a benzodiazepine, and that's primarily to control the anxiety. But controlling the anxiety can also bring down the visuals. And I'm not a neuroscientist, but I've been told that the benzodiazepine can have an inhibitory effect on the release of GABA, and therefore it can actually play a direct role in filtering the excessive visual noise associated with HPPD. And one big problem is the possibility of misdiagnosis. And I imagine this was a particular problem in the 1960s, perhaps before the flashback phenomenon was better known, when, let's say, you were hanging out in Haight-Ashbury in 1967, and you take some orange sunshine and you begin noticing certain strange visuals, the world starts feeling really, really weird, and you go to maybe an old school conservative psychiatrist and you say, I'm getting hallucinations after I took LSD, and it's possible they would have diagnosed you with drug-induced psychosis or perhaps even schizophrenia. Go on.
So, good question. What's the temporality of this? So, for example, let's say I'm tripping today and I get like some symptoms that are sort of like reminiscent of that in 5 years. Would this still be kind of like a diagnostic possibility? Would they say that, oh yeah, you had like a trip 5 years ago and it could be this? Or it does need to be kind of like within the next few days or weeks or...
Yeah, that's another problem with HPPD, is there's never been any definition of temporality. I saw one particular case report that diagnosed HPPD based on symptoms occurring 25 years after the person had taken LSD. And that to me seems kind of absurd. But I think there definitely needs to be better definition, because I'm not sure there's been research on this question, but it seems that at least transiently, it's not uncommon for people to notice certain funny visuals in the days after a trip. I remember the first time I took acid, the next day, my phone keyboard was a bit melty, and then day after it's gone. But I think it's possible that people might encounter the HPPD diagnosis within this time period when it's relatively normal to experience transient visual phenomena. And they encounter the HPPD diagnosis and they think, oh, this is going to be a permanent thing. And I was talking to Irene and Celia about this earlier. I think it's possible that people can prime themselves with the HPPD diagnosis and what would have been a transient phenomenon through fixating, worrying you've damaged your brain, worrying on a never-ending trip, it can actually almost psychologically become a more persistent condition. But if you took, but in answer directly to a question, if you took the drug and then 5 years later you're still experiencing these phenomena, I mean, I think the more important thing is, is it particularly bothering you? If it's not, maybe it's somewhat mundane answer, but if it's not bothering you, then I don't think HPPD needs to concern anyone who's not, and I would advise them not really to read about it. But so a lot of the treatments I mentioned earlier, you can imagine have some side effects. So benzodiazepines are obviously very addictive, although they can provide immediate relief for a patient that is, in extreme distress, and maybe their visuals are fairly extreme as well. So that the actual presentation of the visuals can really vary. It can vary, in the emotional response people can have to them, but there's an extent to which, a certain intensity of visuals, you can't really habituate yourself to it, because visuals can be so intense. So not everyone finds these visuals distressing. A study last year by Levine and David Luke found that distressing HPPD, or when you have these visuals and you're really worried about them, they're starting to take over your life, you're freaking out, is associated with a measure of trait anxiety, a negative precipitating experience, or sort of having had a challenging trip, and a lack of informedness about HPPD as a possibility. And that makes sense to me. You start, if you didn't know that HPPD was a possibility, I think you're much more ripe to then default to a sort of catastrophic mindset. Oh, I've now got this thing, So it's basically a lack of psychoeducation. And they found that non-distressing HPPD was associated with trait absorption, which I would imagine is related to the capacity essentially to sort of relax into it, sort of vibe into your visuals, and not necessarily be bothered by them, and a prior awareness of HPPD. And interestingly, they included a measure of visual apophenia, which, if I can recall, is the tendency to see certain patterns in chaotic or noisy images. So, if you look at a cloud and you see a face, or if you're very prone to seeing faces in clouds, for instance, you're visually apophenic or high in visual apophenia. And they found that that non-distressing HPPD was associated with a high trait visual apophenia. I think it could have gone both ways, really, to that extent. And so I think that anxiety reduction and reframing the visuals you experience is core to resolving the condition. I mean, since the 1970s, really, there's been a handful of case reports on psychological treatments for HPPD, but essentially the consensus from these case reports seems to be that you can not only reduce the anxiety associated with HPPD through, and in these case studies, they use a mixture of CBT, muscle relaxation, attempting to resolve their broader interpersonal relationships. And they found not only that they could reduce the anxiety associated with HPPD, but also eliminate the visuals. So Metefi, 1973, if I recall, this was a 17-year-old who went to see him, who had taken acid and had a very bad experience, and was noticing quite intense HPPD style visuals and depersonalization, derealization. And Metefi takes him through essentially a form of graded exposure, learning to habituate himself to his visuals and the triggers. And eventually he becomes habituated. He's no longer immediately triggered. And this poor 17-year-old eventually was able to completely recover. So I have great hope in psychological style treatments for HPPD, CBT, acceptance and commitment therapy, mindfulness. Then mindfulness, some of you might know, is associated sometimes with depersonalization, derealization. So if you're already feeling slightly wonky in your sense of self, distancing yourself and distancing yourself from your visuals can aggravate the dissociative tendency. And somatic therapies. I mean, this hasn't been particularly studied, but in my own personal experience, that the ability to tap into one's body provides an immediate sense of reality if I'm derealized. And also it allows you to resist the almost colonizing effect of HPPD visuals on your sensory experience. So if you're, in a room here and there are visuals everywhere, you're almost sucked out of your body and into, well, I think that the sensory system already has a tendency to be dominated by visual perception, visual dominance. And I think that visual dominance with HPPD can give way essentially to almost visual colonization. You're not engaged at all with your own body, the rich landscapes of within your own body when you're lost in visuals. So I think I have great hope in these sort of somatic therapies. So yes, one possibility is that it's lingering neuroplasticity. And I won't elucidate too much on this because I don't know very much about neuroscience. But the way that it's been explained to me, that when you take a psychedelic and you increase your neuroplasticity, this has an effect of rendering your perceptual, cognitive, and emotional senses malleable. And I think it's possible that HPPD is an effect of lingering, essentially of neuroplasticity that lingers past the trip. Your perceptual senses have been rendered malleable and they've gone back. You've shaken the snow globe and the flakes have stuck to the outer rim in a way that was different to before. And again, this hasn't been studied, but speculatively, I would suggest that certain hygienes after a trip, if you satisfy them, might render the development of HPPD less likely. So for instance, getting good sleep after a trip, if you continue to take drugs after a psychedelic experience, when you're still neuroplastic, so to speak, I think that could raise the odds. A lack of integration or a generalized lack of real resolution of the experience can leave you still somewhat stuck there, if even psychologically. Disembodiment, stress and anxiety, memory evoking environments. Yes, so in my experience, to put this in more particular terms, I continue to live in my parents' house where I tripped. And so I was constantly reminded of the walls that I'd previously seen breathing, listening to the Beatles. And so it has this effect of evoking certain visual memories and therefore increasing my tendency to sort of have trippy style experiences. And then a fixation on lingering visuals. So as I was saying to you, so it might be entirely normal to have some kind of lingering visual in a week after a trip. But if you fixate on them and you start worrying and obsessively monitoring them, that could render the possibility of essentially looping yourself into a more persistent condition. So here are some representations of HPPD style visuals. So you see someone riding a bike, they've got a halo around the bike. You might be able to see the graininess and the visual static and the morphing. Here's someone staring at their shoes. You might be able to see the sort of psychedelic style rainbow on their shoes and the flashes of colors and the sort of emergence of kaleidoscopic geometric style phenomena out of the rocks and the rubble. And here is a particularly bad instance of visual snow that I found online, where literally your entire visual field is just saturated in static. And HPPD, from the limited evidence that's been done on this, does seem to be associated particularly with colored visual static, as opposed to the kind of visual static you'll see in visual snow syndrome, which is a non-drug condition. And here is, again, an example of HPPD, of normal vision on the right, and on the left, you see after images, geometric layering. Yeah, so it can be pretty intense and pretty difficult to habituate to if you've got significant visuals. So here is a drawing from Abraham, who was the psychiatrist who codified the HPPD diagnosis. It's a drawing from a patient of an anthropomorphic style devil that he kept seeing in surfaces. So there can be, this sort of anthropomorphic, even zoomorphic style visuals people see. Here's some more drawings on the right. Patterns bug me. So, he's looking at some tiling of some description, and they might have been waving around and moving. He's walking down the hallway on the bottom right, and there's a sort of vertigo, walls enclosing on him sort of effect. Bottom left, looking at lamp, looking away, and he sees the after images. Top left, the dots, and the middle top trailing. Thankfully, I was spared of trailing in my own HPPD experience, but this indicates that the kind of symptoms people experience have been fairly persistent well before HPPD and its symptoms were first sort of really getting represented en masse online. And so why does HPPD matter now? So we've got the psychedelic renaissance, we've got trials, we've got studies, and it has been observed partly twice in 2 studies. The MAPS MDMA trial, you guys might have listened to the Cover Story Power Trip podcast. So one of the people interviewed in this podcast, I was able to have a correspondence with, and they forced to me certain details that weren't included in the podcast of lingering visions of cockroaches in their peripheral vision for a year. And by some miracle, they weren't that bothered by it, which is a remarkable feat of habituation, let's say. And a Canadian psilocybin trial. So someone reached out to me on Reddit. The first person to be administered therapeutic doses of psilocybin in Canada in the recent psychedelic renaissance. And they began noticing unusual visuals during the trial, and they didn't know what the hell was going on, so they kind of just ignored it. And I believe towards the end of the trial, they went to the investigator and they said, I'm noticing these unusual visuals. And the investigator told her, you know, HPPD is associated with serious abuse of acid. You know, you're not going to get HPPD. You haven't got HPPD. And so feeling with this false reassurance, the person then later took a therapeutic legal dose of ketamine, which ramped it up significantly. And then to try and resolve the anxiety that had been caused by the psilocybin and the ketamine, they took an underground dose of more psilocybin, and that triggered full-blown HPPD. So HPPD has not actually specifically occurred in its full diagnosis in a psychedelic trial, but nevertheless, in some form, it has occurred. We don't know very much about predispositions or with HPPD. I mean, there's some evidence that people who develop HPPD might be more likely to have sort of tinnitus. They might be more likely to have certain aberrant or unusual visuals before tripping. You know, maybe more visual static in the dark than normal, but it's really hard to be objective about these things. And there is some interest in genetic research around HPPD and in terms of indicating a possible genetic predisposition, but I have some skepticism about genetic research because HPPD, something I'll talk about later, it is not particularly well defined. And so creating a well-defined HPPD population, especially one of a large enough population, is going to be extremely difficult. You know, something else I'll mention is the fact that HPPD is associated with so many different wildly kinds of drugs, not just psychedelics. So how can you define a central stereotypical HPPD subject whose genes you could analyze? So there's rising population use of psychedelic. I think that it's the population in which we'll see probably the most surface area for risk with HPPD, especially adolescents, possibly distressed adolescents. Having read an article about how psilocybin or ketamine or MDMA could help them. So according to some data, we've seen the highest psychedelic use for 40 years in the US, many people motivated by mental health concerns. And there's this possible broad link to trait anxiety, as I've discussed earlier. So I'm going to tell you a story. Here is Glastonbury 1995. You can see it's quite a messy scene. I think that I read that Jarvis Cocker was playing that year. So that's the kind of era we're talking about. And there was a guy called Jay who went, and Jay's now in his 40s, and he was 18 then, and he took acid, a microdot, and something strange happened in the days afterwards. He noticed that after taking acid at Glastonbury, that after images lasted dozens of seconds, and my entire visual field flashed like a strobe light around 8 times a second. Perhaps worse than the visual issues were the intense feelings of still being on a trip. And this lasted for several months, this intensity of HPPD. My thought processes were no longer linear. I felt like I was having multiple thoughts at once, thinking backwards, thinking sideways. This was further compounded by an intense anxiety and depression. And Jay didn't help himself by continuing to smoke cannabis and take MDMA in the days after he took acid and began noticing these unusual effects. But I think that this is quite interesting in pointing at the possibility of some kind of broader complications than just perceptual effects. So he tries to seek help with his GP, My GP didn't really want to know and just put it down to depression, and I was put on Prozac, and this made me seriously ill. I drank a lot to try to cover the pain and would get blackout drunk 3 to 4 times a week. So alcoholism and problem drinking is quite a significant concern in the HPPD community, so to speak, because taking psychedelics, some people do it, again, but it's usually a no-go for many people, and cannabis can make people extremely anxious or make the HPPD worse. And people find that when they get really drunk, the anxiety goes down, the depersonalization is numbed, and the visuals can be brought down as well. So alcoholism occurs. And Abraham, the psychiatrist who developed HPPD diagnosis, so based on the original cohort of patients he saw from the early 1970s and following them for years afterwards, he noted 1/3 of them would become alcoholics. So here's another case study of significant severe HPPD. Stan, Australia. He's an Australian bloke. He might be 44 now. It was a few months since I edited this slide. Anyway, he was pretty young taking LSD. He was only 13 or something, taking it with his brother, and he was taking a lot of it in 1991. And then one day his brother decided to spike him, which is not a particularly good fraternal gesture. And he has had highly intense HPPD ever since, experiences intrusive suicidal ideation and chronic anxiety. He feels unable to really leave the house other than to go to the gym and then scurry back home. He's unable to work. He's impaired and isolated. I think I've got some quotes from him. Yes. So I asked him, what does it look like when you wake up in the morning? And he said, I see billions of fucking dots everywhere. No human being can live like this. It's in torture. He told me, I'll wake up, open my eyes, look over to the right and see tiles morphing, waving, splashing, exploding in a way that it's never gone away. And I asked him, how does it feel to have some people deny that HPPD is real or it's just a myth? And he said, I don't know how you could deny this is real. And that's not to say that people like Stan and Jay, the Glastonbury guy, are at all the majority, but it indicates just how severe HPPD can be. But remember, HPPD is defined by distress. And Abraham, the guy who defined the diagnosis, whilst he was very much of the neurobiological tradition, he came to the understanding that really treating HPPD is about working on the comorbids, as he put it to me. So the anxiety and the depression and the alcoholism that can come with HPPD. So you focus on the depression and the anxiety and the fixation themselves. And there's another story, I haven't got a slide on it, but of someone I know, Sophia. She's quite public now, but her HPPD is now working for the charity. And she had a period of intensive LSD use a few years ago, which triggered, again, sort of Stan level HPPD. And she underwent a sort of self-administered CBT program of literally just teaching herself day by day to expose herself to the visuals, not to give in to the destructive thoughts that she's damaged her brain, that everything's fucked. Excuse me. And eventually, over the course of a year, she was able, again, with abstinence as well, to completely recover from the visuals, which is quite extraordinary. But all the same, even if the visuals remain, living a happy life with them is possible. Here's Abraham, and stress can have a hugely aggravating effect on the visuals. So it's not like they're two independent entities. So the general folk wisdom in the community is the importance of acceptance, time, and abstinence. That's kind of all you can really do, is just accept the visuals as they're presenting themselves in any one moment, and learning not to react in a stressed and sort of compulsive way. Focusing on basic mental health hygienes is another part of the folk wisdom. Exercise, improving sleep and diet, having external tasks. It's easy to get lost when you trigger HPPD in your new condition and becoming sort of, in a way, completely self-absorbed or absorbed in your symptoms. And so for me, I wasn't even thinking about it. It was a kind of therapy. I was lucky that I was distracted by learning guitar. So I just continued learning guitar and just became and escalating in my passionate obsession for the Beatles. And so the Beatles was kind of a treatment for HPPD for me. Prescription drugs, benzos and lamotrigine. But too much focus altogether is being placed on the brain and biology, with HPPD, and I sense there's a gap for sort of psychosocial solutions. So many people with HPPD isolate, and perhaps as evidence of the cognitive effects of HPPD, only last minute realized I should probably put some data from my study in the slides. But nevertheless, I found that off the top of my head, I think it was around 3/4 of people who are distressed or very distressed with HPPD feel they can't tell a soul about having HPPD. So people isolate, and people experience self-stigmatizing and catastrophic thoughts. Perhaps I can skip to the slide that has some of the charts I've got here, slideshow. So this is what I found. So I did a study of 455 people with self-identified HPPD of a range of sort of impairment types. So I included a study that directly asked people, what is your level of distress and impairment from HPPD? And so people who aren't impaired at all, they basically can live as normal. They experience relatively low rates of certain negative cognition. So here's a sample of 4. So the 0 to 5 is an average of one scale, which was the frequency with which people experience a certain thought, and another scale, which was the intensity with which they believed the thought. So you could, even if you could experience the thought of if I have these visuals when I'm older, I won't be able to cope, or can't cope when older. If you don't believe it at all, that's reassuring. But so I took a mean average of the two, and so there's quite a straight line increase from according to your degree of impairment for essentially your negative cognition score. So people who are very impaired with HPPD experience pretty high levels of if I have these visuals when I'm older, I can't cope. Why me? If I could only stop my past self taking drugs, everything would be fine. It's these sort of catastrophic thoughts. And another one, which I haven't seen discussed much in the HPPD world, is the remorse and sadness that comes with the possibility that you will have to give up tripping. So the idea that it sucks my friends can take drugs without me and I can't take drugs was pretty high up there, and actually had a pretty steep association with your degree of impairment. Have we got another one there? Yeah, let's get back to my previous slide. But the sort of point, yes?
How did you rate their level of impairment?
So I had, so there's something known as the tinnitus handicap inventory, which is 10 items asking people about, with my tinnitus, I get down, I'm losing hope because of my tinnitus is overtaking my life, etc. And I essentially just replaced tinnitus with HPPD. And the tinnitus handicap inventory is a sort of validated, well-endorsed clinical measure for distress with tinnitus. And the comparison to tinnitus is I think, quite a valuable one, because they're both conditions defined by an intrusive sensory disturbance that can then overtake their lives, and where the overtaking of one's life and the distress could be mediated by various psychological and behavioral factors that aren't guaranteed or inevitable. So again, I measured sort of brain damage, fear of brain damage. Again, another straight line increase. People with HPPD, really impairing HPPD, are really worried they've damaged their brains. They're really worried they're on a never-ending trip. They're worried that they're crazy. They're worried that everyone will think they're a weirdo if they ever told anyone. And a lot of this is anti-drug stigma. So compared to visual snow syndrome, which is a condition that can actually present itself fairly similarly to HPPD, it's this condition of visual static after images, depersonalization, but it's not triggered by drugs. There's a lot more openness people feel in telling people they have visual snow syndrome. But because HPPD is associated with drugs, there's a guaranteed obstacle to telling your parents, telling teachers, telling colleagues. So a guy I went to school with, he's also had HPPD, and he was finding it very difficult to go into the office because of the open lighting, the people. It was really starting to, should I admit this person?
Oh, yeah.
Yeah. So this friend of mine, he had to tell his boss, I've got visual snow syndrome. He couldn't tell him he had HPPD, because then people think you're a drug casualty, essentially. And I think it's interesting that brain damage is such a concern, because it kind of is the shadow side of the very neurobiological focus of HPPD. You know, it's insofar as you define it as a brain disorder and you overlook the, you know, the psychosocial, the political, cultural context of drugs, then it makes sense people would think I've damaged my brain, because that's kind of the implication, really. And people with HPPD tend to congregate in online forums. So beginning in the late 90s, with the internet starting to take off, self-organizing HPPD communities started to emerge. HPPDonline.com, which has about 18,500 signed up members. They'll go on there, and people who are really distressed and impaired with HPPD can tend to obsess about their conditions and spend a lot of time on the forums. And that could be the only social outlet people have to talk about their HPPD. But really, it can present itself as a vicious cycle of fueling everyone's obsessions with their conditions. And so again, I found that there was a strong association between the degree of impairment with HPPD and the frequency with which you went on online forums. People that aren't bothered by it, they never check a forum. People who are really bothered by it, they might be on it multiple times a day. How to Change Your Mind was the Netflix documentary that came out, I think it was summer last year. So it's a strange time for psychedelic drugs. They're getting mainstreamed and they're very much becoming de rigueur. And I think that there's a possibility that sort of pro-drug propagandas are starting to become equal in power to anti-drug propaganda. And HPPD, so you have this idea of psychedelic exceptionalism, that psychedelics, you know, that these aren't just drugs, these are sacraments, they're plant medicines. And people have a yearning for sort of spiritual, psychological breakthrough nowadays. It seems that more than ever, people are looking for something. And psychedelics quite neatly slot into this hole. There's media hype around them. And I think that this has led to a sort of polarization around how people can discuss psychedelics. Because with all the enthusiasm, people might not want to spoil the fun and talk about the fact that they've developed HPPD. And I think that with this polarization, it can mean that people can have HPPD and might even have had very positive experiences with psychedelics, but they might feel a struggle in really balancing that equation. You know, these psychedelic trips might have changed my life, but now I've got these visuals and they're bothering me, and I don't know how to make sense of this, and I don't know if I can tell my friends. I don't know if I can admit it to myself, because, you know, psychedelics are my source of meaning. And yet some HPPDs can be really, really sad that they can't use psychedelics again, and that this can be their source of spirituality and meaning. And as I mentioned a couple of slides ago, it's interesting to me that so many were so bothered by the fact that they can't take drugs again, although people can take more physically dangerous drugs to sort of fill the gap, alcohol, benzodiazepines. And some HPPDs are drawn back to the well, so to speak. And it is risky to take psychedelics again when you've got these. Yes.
Sorry, didn't mean to interrupt. Just a quick question. You mentioned kind of like this sort of like perception that, oh, we cannot take psychedelics again. Mm. Is this based on anything, any research or whatever? So, for example, let's say I've already got this syndrome or whatever. Do we know what happens if I take psychedelics again? Do we know if it makes it worse or could potentially even make it better? I don't know.
Well, I was just about to get into this. So,
okay, sorry.
So a couple of slides ago, I mentioned the sort of folk wisdom is abstinence. And that's kind of like a first do no harm principle, because it's entirely possible that you can make it way worse through taking psychedelics. And that makes sense to me from perhaps a neuroplasticity angle, or even the idea of disinhibition, that you can aggravate an already aggravated perceptual system through taking them again. But it is possible that people can resolve their HPPD through tripping. I've heard of people resolving HPPD through psilocybin, through further LSD use, through ketamine, through ayahuasca. And some people, they don't really notice any change, which is interesting. And I don't really know the neurobiology of how that might work with the fact people can report no change. But with the first do no harm idea, it's not just, you know, this could get way worse, but there are other risks than HPPD that people often might want to avoid. So in my own experience, I didn't necessarily notice any exacerbation of my HPPD when I was drawn back to the well myself at uni. But then I noticed that I triggered depersonalization, which was a completely new experience, which I triggered through later tripping. And I think it's possible that to some extent, I was already susceptible to other conditions through psychedelics, perhaps revealed by the fact that I triggered HPPD. And so I think maybe it's possible I had a broad sensitivity. So it makes sense that depersonalization came in. And I think that these kind of psychedelic effects can come with a delay. It's not something I've seen much researched is, so a lot of psychedelic studies, it seems, are quite short follow-ups right now, because it's quite a new field. And something I've noticed is that the sort of adverse effects of psychedelics don't necessarily present themselves very, very quickly after tripping. It's not like you take a psychedelic and then, it's not just that you take a psychedelic, you have a depressive breakdown, you then trigger psychosis sort of acutely. With my depersonalization, it was psychedelics and then later on chronic stress. And I think that psychedelics created a sensitivity and a vulnerability that chronic stress amplified. And I believe that because of the very psychedelic way in which the depersonalization presented itself. Like I was back in a trip, essentially, is what it felt like. Okay, this is a very poorly put together slide. But one half of the participants in my survey developed it up to age 18. So it's very young, the HPPD community. And here's something related to the pro-drug, anti-drug propaganda thing I was mentioning earlier. So here's a graph that some of us might be familiar with. It was David Nutt 2010. So you have LSD, buprenorphine, and magic mushrooms in the bottom right. This is harm to users and harm to others. And you have alcohol and heroin on the left. And this was the chart that convinced me that it would be carte blanche to take psychedelics when I was 17. And I sensed that a lot of these quite carefully presented charts, let's say, can have an effect of misrepresenting the risks of psychedelics, especially when you see headlines like this, psychedelics not linked to mental health problems or suicidal behavior, a population study. And whilst, the methodology of a population study might not have found strong association, I think that scientists, and this is being discussed increasingly, need to be incredibly careful about the way that they sort of brand their studies. This goes into the public consciousness, these sort of headlines, Nature magazine, no link were found between psychedelics and psychosis, or magic mushrooms may reset the brains of depressed patients from Imperial. And you often see outright HPPD denialism. So this is a quote from Krebs and Johansson, the authors of the population study. Well, I think that this is actually an interpretation of Krebs and Johansson's paper, that in addition to a lack of negative, acute, or enduring mental health effects, no evidence has been found to support the idea that the use of psychedelics leads to any kind of enduring perceptual disturbances known as HPPD. And it's not uncommon if you're talking about HPPD on like a pro-drug subreddit, for instance, that quite quickly you're going to get piled on. People suggesting that HPPD is a myth, it's not real, it's just in your head. And this is quite a common experience I found in my survey. I can circulate a memo of sorts, the headline findings, which might be interesting. I think a very high proportion of those who were distressed or very distressed felt that they had been lied to about the safety of psychedelics, especially nowadays when there's so much positivity around them. And I haven't checked this recently, but last time I checked, various harm reduction websites either have no mention of HPPD in their sort of risk section, or it's just dismissed as rare with no elaboration, or little known, etc. The sort of shadow side to taking a propagandistic approach to discussing drugs is that it can go the other way. So if you look up HPPD online, you see some quite disturbing clickbait articles, when drugs fuck you up forever, the people who are tripping forever, the man who took LSD and didn't come down for 30 years, for those with HPPD, the acid trip never ends. And these kind of headlines, as well as being deeply irresponsible, have a direct effect on patients. So when you type in HPPD, especially when you're first concerned that something might have happened, and you come across a headline like, when drugs fuck you up forever, it's incredibly distressing and worrying. I think that I first noticed an article in the New Yorker that was headlined, when the trip never ends. This never-ending trip idea is a common one in headlines, and it was extremely worrying. So there needs to be a change in how the media sort of talks about it. I mean, I've even been tempted to contact the editors of these articles, even though they're years old, to try and change them, because they're still there, these headlines. So destigmatization of drugs, I think, is part of a harm reduction project for HPPD. Remember that some kind of visual effect from psychedelics is surprisingly normal, might be relatively normal. Like, it's not just that some fleeting visual effect afterwards is the aberration, but I don't see many people discussing this possibility of some kind of visual effect after psychedelics. Like, it's usually bracketed in the HPPD conversation. And I think it's possible that the more open people are about, when I was at uni, I took acid, and for a good year, things were sort of melting, moving a bit. People being open about these quite unusual experiences they have. I think it can have a direct relieving effect on people who might be at risk of falling and spiraling into distressing HPPD, because they think they're the weird ones. They think they're the ones there's something wrong with them. But actually, it's possible that some kind of visual effect might be relatively normal, and people are therefore ripe for knowing what to expect and knowing not necessarily to worry when they see something unusual with their vision afterwards. So yeah, people, and it's understandable why people don't talk about these unusual visual effects after tripping, because well, who are you going to talk to them about outside of the psychedelic world? You're not just going to talk to your grandma about the weird visuals you got after taking psychedelics. But also, there is the meme of the flashback. People, especially of the old generation, they're all familiar with the idea of the flashback. So people are like, oh, right, having flashbacks then. And people don't want to indulge that kind of anti-drug propagandistic idea. So as I said, the more we don't talk about these effects broadly, I think it sort of ripens the possibility of catastrophic, worrying, spiraling for people that are distressed by them. They might feel isolated, like they're the weird ones. Yeah, their brain's broken. I think this has a temporal component as well, because I think that in the 2 weeks after a psychedelic trip, these kind of visual effects might be relatively normal. And if we can kind of get people in those 2 weeks and sort of reassure them that things are fine, you've not necessarily triggered HPPD, it's not necessarily going to ruin your life. That could really make a huge difference in people's long-term trajectories. Yeah. Right, so. So, HPPD is defined in the DSM as re-experiencing. And I mentioned earlier that people can have all sorts of visual symptoms that aren't necessarily linked to what they saw tripping. But also HPPD is designated as hallucinogen specific. The diagnosis was sort of structured around LSD, but there are non-psychedelic drug causes of HPPD. And people can present identically, having triggered it with SSRIs, for instance. It's something I'm seeing discussed increasingly. People have developed it through, just cannabis and MDMA, which aren't stereotypical classic psychedelics. And it also overlaps significantly with other conditions. This visual snow syndrome. People can have unusual perceptual experiences with kinds of epilepsy, migraine with aura, anxiety, and panic disorders. That was an interesting one. This hasn't been much studied, is the visual symptoms associated with anxiety. But I've seen in online fora and in sort of anxiety information websites that it's quite common to see reported that when you're panicking, you can see sort of bright spots. You can maybe even see geometric patterns are seen reported. So the link to anxiety is quite a complicated, interesting one. Schizophrenia, there can be some overlap. PTSD. And so one issue is, we've structured the entire diagnosis around this quite simple linear equation of sort of just drug-induced perceptual problems. But really, I think that it's possible there's something far more complicated that's going on here. And there might be a general tendency to these kind of symptoms that can be induced by drugs, but also could be induced by other things that people might have developed it anyway. But I think it's also possible that HPPD really, in certain core ways, is qualitatively distinct to visual snow syndrome and anxiety, because it's not common for people with visual snow syndrome to sort of notice kaleidoscopes geometric patterns. That might be what's different about the psychedelics. So more than being drug induced, it might be that HPPD is just drug infused. You know, it's a certain subtype of a broader possibility that has just been sort of psychedelicized in a way. Yes, and I think, you know, in general, there's a lot of stigma around the idea of, you know, seeing things, sanist ideas. If you're seeing something aberrant, there's necessarily something wrong with you. So I think that destigmatizing HPPD is really part of a broader project of opening up about how weird all of our perceptions can actually be. So here is just a mind map I made of all the different conditions with which HPPD symptoms can overlap. I'm sorry if it's not particularly legible. This was made on a website we had to pay after making the mind map. And I decided to take a screenshot anyway. But anyway, you know, non-hallucinogenic drug induction, SSRIs, antipsychotics, visual snow syndrome, certain neurodivergences. I've seen autistic people report that they have a lot of visual snow and after images. I've seen people with ADHD report a lot of visual static. This hasn't been much studied, but this is based sort of on just looking at online forums, depersonalization, derealization, PTSD, head traumas, psychosis spectrum conditions. I've even noticed, well, there have been a couple of studies I found on the visual components of depression, anxiety and stress. I can send you this afterwards if you'd like to study it. So here is a chart from my study, which kind of indicates the range of emotional responses people can have to HPPD. I've just noticed that my cumulative percentage table is the same as the valid percent, but you can see that most people were situated. It's not guaranteed that you're going to be really impaired. You know, most people, more than 50%, trying to do some mental maths, were between not impaired at all and somewhat impaired. And that's what's critical here, is that you can be fine with these symptoms. 45% up to age 18. From my study, most people took LSD. What was interesting was that there was a considerable role for dissociative drugs like ketamine and DXM and deliriants. I saw DPH mentioned a lot, which is the drug found in Benadryl. So again, this idea that this is just a condition of classic psychedelics needs to be weakened. Most people hadn't sought diagnosis, and 70.8% suggest they didn't have another condition. But the number endorsing another diagnosis increased broadly with impairment types. People who are really impaired, again, there's small numbers, but versus, you know, 1 in the less impaired and 6 in the very impaired had bipolar disorder. So it could be there's just a general psychological vulnerability that's associated with really impairing HPPD. So here's that chart again. I'll show you a different one. So, you know, it sucks my friends who don't have HPPD can still take drugs and have fun without me. Among the very impaired, 60% experience this worry often or very often, 40% experienced it very often. So what percentage believe dismal claims about HPPD to be probably or definitely true? So, you know, no way that I can tell anyone else about HPPD. So actually, it's quite consistent from the somewhat impaired to the very impaired. More than 60% believed it was probably or definitely true they could never tell anyone about HPPD. So amongst the variant, there's a line of increase from, you know, I'm going insane, I've damaged my brain, I'm stuck on a permanent trip. So again, it indicates that, you know, these kind of really destructive thoughts aren't guaranteed or inevitable. And that to me indicates promise for sort of psychological treatments for HPPD. So maladaptive behaviors, forgive the jargon, but essentially the people who are very impaired were much more likely to, you know, to try to act normal. You're having a flare, and rather than opening up or telling people that what's going on for you and seeking a safe space, you try to act normal and you repress. And that was a very common experience, people who are very impaired. Among the very impaired, a very large proportion noticed that they would frequently get distracted from their task by HPPD, which must be tremendously frustrating. More than 50%, often or very often, amongst the very impaired, if they notice a flare, will not socialize or engage in any other activity. They will just sit and, I assume, stew in their distress. You can see amongst the not impaired at all and mildly impaired, these kind of destructive, almost kind of behaviors you see in many anxiety disorders. They don't occur as often. Reassurance behaviors. So people who are really distressed with HPPD will sort of often go over whether what they're experiencing is normal, monitoring and scrutinizing in an almost OCD-like way. Think about how they developed HPPD, so going over in the past and thinking about the trip, thinking about what they did wrong, go over it's really HPPD. So it's interesting that there's an increase from the not impaired at all to the impaired, but slightly fewer amongst the very impaired, perhaps because it's less undeniable they have these symptoms. Yes, so people who are very impaired quite frequently check on their visuals, sort of check, how are they doing? Are they changing? How is it getting stronger? Is it getting weaker? Am I getting better? Or monitoring their body for unusual sensations. Again, so to me, this indicates a broad somatic symptom disorder style profile. People are just sort of really getting in their own heads about what's going on. This is quite an ugly graph. I asked about the degree to which people believe certain statements about HPPD. So there's a broad line of increase, perhaps, from the non-impaired at all to the very impaired, in believing that visual snow is necessarily a sign of a disorder. So, if you're in your bedroom at night, you notice the static. If you're very impaired, you're more likely to believe, compared to the not impaired at all, that this is something wrong with you. So, and to me, that indicates maybe a poverty of psychoeducation or discussion about what the perceptual system can sort of vary and look like. So people who are very impaired are more likely to believe there are no HPPDers who live normal lives. They're less likely to believe that anxiety is associated in any way with visuals. And they're more likely to believe that only people with, textbook HPPD will see visuals after taking drugs. So they associate HPPD and their diagnosis with the whole spectrum of post-drug visual effects. So that was the correlation between a regression of an overall sort of cognition score, or an overall calculation of the intensity and frequency with which people believed or engaged in destructive thoughts about HPPD, and then it also included obsessive monitoring and scrutinizing behaviors, and there's quite a strong correlation with the degree of impairment. And so this, to me, indicates a CBT style formulation. So the HPPD distress might be shaped by quite a common set of catastrophic thoughts and destructive core beliefs shaped by poor education and misinformation, but also behavioral patterns and safety behaviors like you'd see in OCD or other anxiety disorders, monitoring and checking symptoms, avoiding environments and situations. And HPPD is a kind of visual tinnitus. So people with tinnitus who are very distressed by it, it overtakes their lives. They can't stop thinking about it. They can't stop monitoring it. And HPPD could be a sort of visual analog to that, albeit one that's unfortunately situated in our quite messed up culture around drugs, which adds a whole other layer of problems. And these are the case reports I mentioned earlier. That's just a few of them that found that applying a kind of CBT approach not only relieved people's anxiety and distress, but actually had a directly treating effect on the level of visuals, which was quite striking. So here, this is a formulation I found for tinnitus. So you hear the tinnitus tone, you immediately feel anxious. And if you go on the right-hand path, you think, I don't like my tinnitus, it interrupts everything I do. It's a big monster, it takes away my silence, there is no peace. That causes you to become more upset and frightened, you become physically tense and anxious, and you get in this sort of cycle. And I think that something similar goes on with HPPD, where you have a visual, and maybe the visuals have been intensified by stress, fatigue, being in a dark environment, stimulation, some kind of intoxication, and you have the initial emotion of anxiety and panic at what you're experiencing. And that leads you possibly to approach it catastrophically, destructive core beliefs that, you're messed up, your brain's damaged, everything's ruined, you isolate, and you monitor and fixate on your visuals, and the cycle's maintained. As we approach it situationally, you take action, you can address the source of why your visuals might have been intensified, you could let others know, and you could engage in deep breathing, almost distract yourself, get the guitar out, for example, engage in a sort of mindfulness, and you can start to recover over time. And something else I haven't seen much discussed is the spiritual qualities of HPPD. So it's not surprising that amongst a group of people that use hallucinogens, many of them are interested in spirituality. And many people in HPPD turn to meditation, or other people are drawn back to psychedelics. But depersonalization, derealization especially, is quite complicated in sort of differentiating that from the kinds of states of consciousness you find described in Buddhist and meditation literature, for example. Depersonalization to an experienced Buddhist practitioner could be the enormous, gratifying sense of interconnectedness. So that there always needs to be this spiritual context within which you're discussing these things. And I'd like to see more research on how indigenous cultures, for example, might approach these visual effects, if they do occur at all. I mean, there was one study in 2006, I believe, of 500 Native American church members, frequent users of peyote, and they didn't report any persistent visual effects, which is quite interesting, and I'd like to see more work on it. And the depersonalization, derealization stuff is really difficult to handle because, in my experience, I myself was wrestling with, are these experiences are they interesting? Are these states spiritual? And it's really difficult to navigate that sort of intense psychological territory just by yourself. And I think that the individualism created by the loss of religions and collective communitarian places to discuss these experiences has been a real tragedy, really. I mean, not to say that necessarily the Anglican Church would have been the right place to open up about your derealization. But yes, HPPD can feel very spiritually deprived after losing psychedelics as a tool, and there can be a mourning period. And I've got this picture of Henri Frédéric Amiel, who was a French academic of the 19th century. And he wrote this book called Amiel's Journal, which posthumously became his great work. He never published anything of particular note during his life. And that was because he spent most of his life in this precise, weird state of unknowing about whether his feeling of a loss of self and the world feeling incredibly bizarre and unreal, was it spiritual, was it not? And he wrote this quite extensive book in which he was exploring all the weird experiences he was having. And it's an amazing document of the fine line between DPDR, especially, and exotic states of consciousness that aren't necessarily pathological at all. And it's incredibly difficult to discern these things. So yes, the charity I work for, we publish a quite extensive information guide about HPPD. And we also have a directory of specialists, so psychiatrists, counselors, therapists, psychologists who are directly experienced in helping people with HPPD. We've been able to connect a lot of people to them through that. And a really good book on depersonalization, derealization from a CBT angle was this book by UCL's Elaine Hunter. That was sort of the inspiration for me pursuing a CBT concept for HPPD. So that is my talk. Take a seat in the field. Any questions you guys might have? I'm sorry for the slightly scatterbrained nature of the presentation. I can only blame it on the acid.
This was great. Thank you very much. If any questions, there's some clapping from the online audience as well, I see. Yeah, does anyone have Alex?
You said you, after your trip that induced HPPD,
Yeah.
you tripped again.
Yeah.
How was that experience for you?
Oh, I tripped many times after, and it was great. It was great.
Did it intensify anything, or?
I think that there was a temporary intensification of HPPD symptoms, especially if you're in a lecture and you're just sort of staring out at the lecturer down there, you can start to sort of trip out a bit. But the real, I regret taking psychedelics again, honestly, although it was really fun because I think that I would have recovered had I just left it. But then taking a lot of psychedelics again then just triggered the depersonalization, derealization. And a point I didn't really mention actually was that for many people, it's this depersonalization, derealization that's the real kicker more than the visuals. Because derealization has this curious effect of always feeling novel every time it comes on, in a sense. It always feels, at least to me, it's always felt like the first time when you feel derealized. And I think that's kind of an effect in all anxiety disorders, really. Oh, this time something really bad's happened. This time you need to worry. So yeah, those are my experience. Maybe I think perhaps I might have tripped harder than people I took it with, maybe because I had a more sensitive visual perceptual system. Yeah.
Have you come across people that were that had subsequent trips that actually helped them to overcome their HPPD?
Yeah. So as I mentioned earlier, there have been people that have reported literally the next day or so, the visuals just go away after they trip. And I don't know how that necessarily, I'm sure there's a neurobiological explanation for how that could work. But one really interesting guy I was told about by John Halpern, who's an interesting character. John Halpern is a psychiatrist, and also he was a DEA informant, and he's also an HPPD expert. And he was telling me about a patient he had who was actually a part of the psychedelic community, who was greatly involved in psychedelics and had a great amount of belief in them, and there was core to his identity. And then he takes ayahuasca and has a shattering experience, and it leaves him with severe HPPD symptoms. And then it really overturned his life to lose the sense of meaning and identity that psychedelics brought him. And then he decided to take ayahuasca again, and it seemed to resolve the distress or the shock or perhaps the trauma of his ayahuasca trip before. And then the next day he was clear, it was gone. So these interconnections of the neurobiology and the psychological and the social, I think are really rich. It's definitely a biopsychosocial phenomenon.
The people that they did find it helpful to go back into the psychedelic experience, was it that they did it with the intention to resolve it?
I don't know, actually. I know a lot of these people I've seen have just sort of mentioned it in a single line on a Reddit comment, like, oh, I took ketamine and it caused my HPPs go away. I should probably follow up with them. But I think I recall at least one person who said that they took psychedelics with the express purpose of having an intensive hours-long experience in which to habituate themselves to visions. If you're fine with tripping when you're actually tripping, then maybe you can be fine with tripping when you're not tripping, so to speak, crudely. Yeah. And I think that person did find it really helpful. It's like, oh, it's not so bad. It doesn't have to be so bad. That was one interesting report I heard.
I was going to ask about the data you showed us. You collected that yourself, right?
Yeah.
And what was the sample size? I might have missed all those details.
That was, sorry, again, I can circulate more details on it if you like. So it was 455 people, although
online.
Yes.
And did you take, because the main thing was intensity was associated with everything nasty, right?
Yeah.
I wondered if there was any demographics or did you collect lifetime dose, or was there anything that predicted intensity? From sort of background information about the characteristics of the individual.
Well, a few things that I should fill in the gaps. So I also took measures of people's direct visual symptoms. Actually, I'll answer your question. So in terms of drug history, my survey was quite long, so I wasn't able to include a detailed section on their full drug history, but or the number of times they'd taken psychedelics. But the most interesting thing perhaps was that, again, it confirmed a finding previously in the literature that LSD was the drug most associated with HPPD. But
of all the different drug classes.
Yes. But but also a non-trivial number of people indicated they thought it might have been, as one person put it, they thought it might have been fake acid. So like I saw people mentioning, I'm pretty sure it was actually 25-INBME, for instance, the research chemical. A non-trivial number of people reported that it was actually 1P-LSD, which is a research chemical. And I also took measures of people's visual symptom levels. And this was done using a fairly rough and ready measure, right? Was able to find a website where you could create graphic representations of certain HPPD visuals, and you could increase the intensity on a 1 to 5 scale. And I found that there was actually no significant association between 3 types of visuals. This was the static ghosting, which is an effect where basically like faint. Oh,
Thank you so much. I've got to go do something else.
no worries. Thank you for coming. And ghosting is this effect where you look at an object and it's somewhat related to after images, but you look at it and there's a ghostly, hazy replication of the object you're looking at it. So I had a measure of visual static ghosting and halos, or the shimmering aura around an object. And I found there was no significant association between the level of distress or the intensity of these visuals, which is interesting. You might expect people who are very distressed with HPPD to have very high levels on these visuals. Then these aren't necessarily representative of what people's HPPD looks like. So if I was to do more research, it might be interesting to create better replications of HPPD visuals.
You'll get a load of intercorrelations between all the different measures anyway. Crowd effect. Like
Yeah.
someone says nasty on one thing, they say nasty on another thing. So I wouldn't necessarily read too much into those. But what you really want to find is whether there are any reliable individual differences in the risk of having the event, the intensity at all, like age, ethnicity, poverty levels, prior mental health diagnosis, dose levels, polydrug use. No, there were no associations of those sorts.
People tended to be very young anyway in the HPPD, or tend to be young in the HPPD sample. There were no interesting.
Wasn't enough variation in age to make that meaningful comparison.
No, there was no particular difference on ethnicity. The majority of the sample were white men, and I did include a measure of financial stress, and I was expecting there to be an association but there wasn't a significant association. Although people who had very intense HPPD were, I think it was more than a quarter were disabled and unable to work.
That was afterwards.
I don't know. I should have. That was my own omission. I didn't ask for elaboration on that. But yeah.
Still don't know who gets it.
Well, actually, one thing I should mention is that people who are very impaired with HPPD were more likely to have had a very low emotional quality trip. So I had 0 to 100. 100, I said, that the experience was heavenly, and it was the experience that you associate most with triggering your HPPD. 100 was heavenly, the classic good trip. 0 was hell, the classic bad trip. And people and there was a fairly straight line association, people more likely to have had bad experiences, so to speak, with more distressing HPPD. And that could be related to, a few things. Could be underlying trait anxiety and neuroticism, or it could be the direct actual value add of having had perhaps a traumatic experience in creating the kind of symptom presentation.
I think the anxiety and then like focusing in on the symptoms that arise and it can sort of really suck you into that. It's like with tinnitus, as you said. I heard a really nice thing about tinnitus. Like a monk once said, it's like the sound of silence, and that kind of helps people then realize that it's a normal thing. And it's quite, so I just wonder about the visual stuff. And how that could be seen to kind of
you should whack that data into a network model and partial out the effects and see what remains as the key predictor of intensity. Because everything's correlated, right? So you need to work out what's the unique predictor, but you might not have enough power for that.
Right. Okay. It's a good suggestion. Not particularly advanced statistician, but that's good to hear. Yes.
Collaborations.
So it seems like the perceptual effects are mostly visual.
Yeah.
or are visual.
Mm.
What about sonic or tactile?
Good question. Auditory phenomena seems to be relatively rare. I mean, insofar as you could even call tinnitus, I suppose it is technically an auditory phenomenon, but that's the only one that people consistently report. I mean, I have heard of people reporting hearing. This does seem to be relatively rare, but I've heard people describe, that they feel like someone is doing if you want to designate that as perhaps an auditory hallucination, but at that point, maybe that's where it starts to go beyond the stereotyped HPPD profile and something maybe slightly different. But again, yeah, auditory stuff seems to be relatively rare. Tactile phenomena, I suppose, to the extent people experience a range of somatic style symptoms. So I think before you arrived, I was describing this phenomenon of the head pressure people experience, feeling of like their head feels like it's throbbing, feels highly pressurized, or people might feel various unusual bodily sensations that perhaps they first experienced with psychedelics. Feelings of electricity running through the body, these kinds of things. And then something else, I did ask people to just, if you have other symptoms, I didn't mention, please discuss. And people discussed a whole quite a striking range of things. I mean, some of these I'm pretty sure is just health anxiety or hypochondria. People discussing organ pain, for example, or like lung pain, for instance, and they attributed that to HPPD. I think that's probably an effect of hyper monitoring of their body sensations. But also quite something I hadn't seen discussed initially before was this issue with balance. It's people walking or moving, that they feel that their balance system has somehow been altered. If one person said it feels like I'm trippy again in terms of everything seems a bit off. If I feel like I'm going to fall over. I don't entirely know how to make how to approach that.
Maybe to do with the awareness of the body and where it is in space and complexity.
Yeah.
It's problematic for the category of HPPD as a category in the DSM. It's a disorder. Other forms of disorder have been become spectrum disorders, basically. But here is like this. It seems like an umbrella term for comorbidities, because especially if we want to speak about a persistent psychedelic experience, well, the psychedelic experience usually has auditory effects. It has this synesthetic of a mixing of sensation. If it's just visual, then it's really not a trip,
Right?
And let's say, and we're talking about something else here.
Right.
And
I think HPPD is again a great case study, as you say, in the limits of diagnostic categories. Because I think especially because the HPPD diagnosis itself has a psychoactive property in itself. I'm not sure if you were there to hear some of this discussion, but the idea that people can encounter the HPPD diagnosis and fixate on it, on the diagnosis itself, and that can start to structure and colonize their experience. And I would be curious if in an alternate universe to run a sort of control version of my own life where I never encountered the diagnosis. Perhaps if this was like the 90s, early 90s, and I just, okay, well, it's got these weird visuals. Yeah, I mean, it's entirely possible that I would have recovered sooner or been less distressed had I never encountered it, or even never encountered that depersonalization as a possibility. So I knew that this was a thing before, and I felt blessed not to have triggered it. Then later, when these certain effects began kicking in, I was like, oh, that must be depersonalization. And then that started to structure and define my experience. So again, there's always this need for, really taking these diagnoses quite lightly. And really, and when someone seeks professional help, really taking them as an individual. There's always going to be anomalies under this umbrella. People's experiences will be highly individualized.
In a couple of your slides, didn't you show that there was associations between not knowing about the existence of the disorder and having worse outcomes, which is the opposite of that, right?
Right.
And there was 2 such studies you referenced, I thought.
Right. Well, with with my study, that was asking about whether people believe that HPPD means any kind of post-drug visual effect. I.e. that having any kind of post-drug visual effect is necessarily a condition. And if people, and I think that makes sense insofar as if someone experiences a visual and they think, oh, this is that condition, they're more likely to go into a catastrophic way of thinking. But I think you make a good point. I think that prior awareness of the disorder, it may in general predispose towards maybe having a less distressing kind of HPPD. But I mean, very anecdotally, and I think I'd like to see perhaps more research on this, is that I think that it can go both ways, really, in terms of the subjective effect of awareness about the diagnosis.
So knowledge can make you worse for low intensity and better for high intensity HPPD. So it's a quadratic curve.
I don't know. It's possible that people who are really distressed by HPPD, they're thinking about HPPD all the time, and they're thinking about having this disorder, and it's really bothering them. Whereas if they just treated the symptoms as they presented themselves phenomenologically, it's possible that they wouldn't have, associated this with a disorder, or may have just experienced their experience as experience. If that makes sense.
Is that what your point with the Native American Church was? That
Yeah.
people might experience? But they reported no symptoms like this whatsoever. So, but that was in a small sample. But
Yeah,
that would be interesting, wouldn't it? Like kind of cultural comparison.
Yeah.
I think with somewhere where this is sold as just a reasonable experience to have.
I think
Or maybe even said that's kind of positive experience. I mean, is there a culture where this is viewed favorably?
Again, I haven't heard really anything about indigenous cultures and these kind of things. I spoke to one integration therapist who told me that they knew about a shaman who had it and had persisting visions, and it was treated as some kind of communion with spirits of some description.
What you were saying about the casinos, because that's a practice
Right.
where you see lights and visuals all the time. So rather than feeling the sensations, you see the sensations, so around you all
What
the
is
time.
that? Sorry, Jan.
It's like a bit of practice of meditation.
Ah.
It's like pat out tradition.
What's it called, sorry?
Pat out. It's Burmese guy, Burmese monk.
Oh, wow.
Yeah, Buddhist tradition, and they
you-
rather than noticing sensations, they see
Understand.
the like particles. And they
Ah.
walk around. That's what the casino is. It's like
Through the
to
practice.
help you. Yeah. So there's a book called Fishudimaga, which is like the path to purification, to purify the mind, and part of that is to call upon these visions, and then you see them all the time, but then they just come into your field. So it's more, I think you can call upon them rather than them being around you all the time. But it's really, it's quite interesting.
Have you found in any of your participants or people that you've spoken to that they found a specific framework, like metaphysical belief, that helped them make sense of their experiences?
Yeah, I did have I think it was, I can't remember precisely how many, but enough to be somewhat interesting. I think it was maybe 15 people or so said that they interpreted it as some kind of spiritual phenomenon. A few people mentioned magic and the occult, but most people just seem to go for a sort of informal, non-pathological framework. This isn't necessarily a disorder, because or that once you accept it, it doesn't have to be a big deal. This is just the way I see it, which is, yeah, I think that's how a lot of people tend to approach it. But the spiritual stuff, I didn't find much that was particularly concrete about differences in philosophical beliefs or with HPPD.
Or whether it helps alleviate the
Yeah,
distress to
yeah,
find a way of making
yeah.
sense.
Going back to the discussion about the category, whether it helps to know, or if it's sort of like a feedback loop. I mean, certainly like a category is certain weights on your framework that is filtering out all other information. So you see that, but basically the vagueness of the category itself is very important because it's a very vague category. So I'm thinking like if it is almost exclusively visual, then it's the visual should be at the name, and then it becomes a very different kind of condition, a very different, and the way of approaching it and studying it and resolving it becomes very different, because it's like it's about basically you can incorporate practices of visual mindfulness and meditation into that, or you can actually do neurobiological studies on the visual pathway, rather than just looking all around and knowing where this comes from.
Right.
So I wonder if something like this has been done in this world of HPPD research.
As in,
People have been looking at the specifically, like trying to categorize it as visually, as a visual first condition.
that was the original formulation. It's come to inflate over time. But
Okay.
it was originally visual, but it's inflated, and that's actually something I've seen in other disorders that are very online. There's one I came across called post-finasteride syndrome. Finasteride is a hair loss medication, and what might have begun as quite a constrained stereotype set of sensitive people experience this medication has been wildly inflated. So like, I mean, this could speak to the complexity of the human body and the human mind, the kinds of symptoms people experience, but nevertheless, if you look at the symptoms list, it's everything from, organ pain, numbness in your fingers, anxiety, depression, to the point where it loses a lot of its explanatory utility, apart from just it was caused by finasteride. But even there, it's really difficult to isolate finasteride as a cause in and of itself, right? And I think that something similar has happened with HPPD. It's become quite inflated, and I don't know exactly what the approach should be. I mean, I've thought about this idea of creating a broader non-pathological supra or a super category, sort of like just post-psychedelic visual effects that aren't necessarily pathological, and maybe HPPD is nested in there to really isolate this actual like psychiatric disorder. And also that provides a sort of language for people to discuss visual effects that aren't necessarily bothering them, because you see, because the term HPPD, which is very much or should be characterized by this distress and this overtaking of one's life, has become just a catch-all term for visuals altogether. So you'll see people on Reddit like, I have HPPD and it doesn't bother me, but that's a contradiction in terms.
You can make the final D distress instead of disorder, right?
Yeah.
Which feel nice to say.
Yeah.
And then nesting it within the broader category makes a lot of sense.
But again, like if it is hallucinations, then it's not specific to, I guess, to ask through an example. Someone was telling me about having, they had a really bad cannabis trip, and around that time they were struggling with like just hearing like this cracking noise or like this, this annoying noise that was like intruding, and that was around the time that they had a really bad trip. And then whenever they would have like cannabis after that, it would bring back like these auditory hallucinations and then trigger it for afterwards as well for quite some time. Would you consider that a form of HPPD, or because it's auditory, it wouldn't really fall into that?
Well, I don't know. It's one of those difficult boundary cases, isn't it? I mean, it's possible. I don't entirely know how to answer it. I mean, if we're going for a really broad definition of HPPD, then maybe that would be a good term to use. Yeah. But that is an interesting phenomenon though, in general, of cannabis seeming to throw people back into a psychedelic style state. Weed is different after you trip, so to speak. And if you look at the original literature of the 1960s, 1970s, in studies on flashbacks, basically they didn't separate people who reported flashbacks in everyday life from people who only experienced them stoned. So a lot of these studies were quite muddied, and back then, what might have been just being stoned and maybe just the kind of associations that your mind can draw when you're in an altered state. You're stoned and there's overlap with previous psychedelic states, and maybe you've come across this idea of the flashback in the media. So you think, oh God, I'm having a flashback. And not sure I was going with that, but anyway, that's an interesting feature of the old literature, is that they're all confounded by most of them. I mean, I think there are, in a few studies, most of the people only ever had flashbacks when they were stoned. So
Yeah, it seems to be like some sort of trigger for associations that you have somehow bound to that first experience.
Yeah.
Yeah. Any other questions from here or?
It's quite a reductionist one, but it's about the lamotrigine and does that help then with people's?
Yeah.
That's like obviously using epilepsy and it reduces the prefrontal cortex. It's interesting if there's something like, well, you mentioned all these overlaps with epilepsy and maybe migraine, I don't know. And but does it stop them altogether or like?
It can have a huge reduction in symptoms.
Yeah, it's been
I haven't seen any. There's never been a trial on lamotrigine for HPPD. I think there's been case reports and stuff. Yeah, I mean, I tried to get lamotrigine, but that's when I was told you're not allowed it because there's never been any randomized controlled trials. So there's no grounds for us to be able to prescribe it. So I guess the people who have been given lamotrigine are all American. I know is it a bit more, is it a bit looser there? I don't know.
That's you should be able to get it maybe off label. I don't know.
Yeah.
I'm not getting. I'm not offering you much. It's interesting to know what it like to have that experience when what it felt like. Yeah, it's interesting because epilepsy stuff is interesting and migraine as well. It sounds like the visual, the aura of the like the kaleidoscope aspect of that. I don't know. Yeah, it's really fascinating. Thank you. Sorry.
Yeah, no, I was just gonna check because Louis has just rejoined as well. If we have any other questions from online, because we have gone quite a bit over time, but maybe some final questions. Online or in the room? Oh, yeah, Louis.
I'm sorry. I was in and out. I things here, so I was listening to the lecture and then I have to be called in the garden and come back. So I'm sorry I missed a lot, but anyway, I've been following. All right. So thank you.
Sorry, one last question from me.
Yes.
Has anyone tried, as far as you've looked at the literature, to use antipsychotics in this context?
Yeah. So I think the antipsychotics, pretty sure it's mixed. I mean, there have definitely been case reports I've seen of antipsychotics having a significantly exacerbating effect. I think that the ones that I've seen, they prescribed risperidone, if that's how you pronounce it, or risperidone, and it had a directly exacerbating effect. And that's one of the sort of risks of associated with going to a clinician that doesn't know about HPPD, because they might just opt to prescribe you an antipsychotic. And I think that that's been an experience of people who have been perhaps misdiagnosed with a psychosis spectrum disorder. They get prescribed an antipsychotic and it can, directly exacerbate the visuals. But I'm again, this is off memory. I'm fairly sure there have been some instances of it helping some people. I mean, a similar finding with SSRIs, like the conventional wisdom was that that you shouldn't give people SSRIs because this might be because if it was triggered by a serotonergic drug like LSD, in people SSRIs might exacerbate the visuals. But I mean, I've seen that some people benefit from SSRIs. Some people, it does get way worse, and some people trigger HPPD style visuals from SSRIs. So it's incredibly complex. Yeah.
Is there a link between OCD and HPPD? I think you might have mentioned it.
Yeah. I think that there's an extent to which really distressing HPPD can have significant overlap with OCD. Although in my study, there was no significant association between people having also another diagnosis or identifying with OCD and having HPPD, having really distressing HPPD. Yeah.
Thank you.
I have a question. I don't know if it is too crazy, but in the shamanic societies, when you have visions and you have all these, very often what you do is to try to engage with whatever is there. like asking, what do you want? What is it? I mean, there will be some kind of intersubjective, perhaps you are just talking to yourself, but is there anything, have you heard anything like that in this kind of cases where people seeing vision, not taking anything, and some kind of engagement, with yourself? Because in a way, it is your unconscious mind or something is talking to you. Do you have anything to say about that?
I think that's an interesting way to approach it. A psychotherapist I know actually asked me the same question. He said, have you ever considered talking to your HPPD as a person? But no, in terms of discussing it in an academic context or in any case reports, I've never seen it. But that makes sense as an approach. Yeah. Yeah. No, I'm sorry if it's not a more elaborated answer. I just haven't seen that discussed very much.
I mean, this is not the kind of things in academic circles, because we live in a materialistic world, in which animism is nowhere, So yeah.
There's a question from Nikki in the comments.
Yes, the question is, what we see is mostly constructed within our brains by our prior expectations and our existing memories of objects, etc. So disruption to this process is easy to comprehend from a change of focus or expectation, effectively magnifying the new ways of perception. So is HPPD associated with earlier experiences of psychedelics or equally common in those who have tripped multiple times previously?
We don't know very much about the number of times people have taken psychedelics and then developed HPPD. I mean, the only study that I can draw on is this stuff that was done by Abraham, where he found that, I'm not sure of the proportions or the number of people that were in each group, but he found that there were 4 broad buckets from his original patient cohort, people that had taken psychedelics 1 to 5 times, and then another maybe 5 to 10, another 10 to 20, and then another more sort of 20 to 50, etc. And he found that I think actually fairly uniformly people were distributed into either of these buckets, and so that's why he speculated that HPPD was primarily genetic, and that there can be a genetic component to sort of your sensitivity or the number of trips at which such a sensitivity is activated. But in terms of your specific question, I don't know. I don't know is the answer, really.
Yeah, so I think we have, thank you for a great talk. Further research is necessary, as Nick is saying. Very true, very true. Thank you so much for coming here today.